Good afternoon, everyone. We'll be getting started in just a moment here, but before we get over to today's presentation, my name is Brendan Donahue, and I'll be helping run the webinar from behind the scenes. And I just want to give everyone a quick couple housekeeping topics before we move into the actual content today. If you are connecting to this webinar from your computer, you have two different options to listen along. You can listen with your computer speakers, or you can dial in on the telephone. And my word of advice to you is that if you are dialing in on the telephone, just make sure that you choose the telephone option on your webinar control panel to match. There's also a PIN number that goes with that. And if you're connected with the telephone option selected on the screen, that will really help reduce any unwanted feedback that comes from the computer. So make sure that you've got the appropriate option selected here on your webinar panel to get the best audio quality. If you want to ask questions to our presenters at any point during today's presentation, you can do so by typing them in on this same control panel. And we'll be taking time for questions at the end of the presentation, but please do not feel like you have to hold your questions for the end. You can type them in here, and we'll try and address as many of the questions as we can. Now, today's webinar will be recorded, so if you'd like to view this again in the future, it'll be archived and available for future viewing. And we'll also be sure to send out the slides and any other pertinent resources mentioned during today's presentation in follow-up emails. Follow-up emails from today's webinar are generally sent out between 24 to 48 hours after the webinar ends. So if you haven't seen the email later on this afternoon, don't worry, it should be out in the next day or two. So I think that's it for my housekeeping topics for today, and to give us a quick overview, I'm going to hand things over to my right, and it's Ned Loughran. Ned?
Hey, Brendan. Good afternoon, everyone. I'm Ned Loughran. I'm the Executive Director of the Council of Juvenile Correctional Administrators, better known as CJCA. CJCA represents all the state and some county directors of youth corrections across the country. Our mission is to connect, develop, and strengthen youth corrections leaders so they may implement and sustain reforms in their systems to improve outcomes for youth, families, and communities. We believe every youth should leave a correctional program in a better place than when he or she came in. We're pleased that so many of you have joined us for today's webinar. By last count, we were over 800 registrants for this trauma-informed care webinar, the first of our 4 webinars we're going to hold on trauma-informed care. Today's webinar is being conducted by CJCA's Mental Health Work Group that is made up of many of the directors of clinical or mental health services in state and county youth correctional facilities. The director of our, or the chair of our leadership of our mental health network is Jennifer Jaworski, who is the director of mental health services for the Department of Juvenile Justice in Illinois. And with that, I'd like to turn it over to Jennifer to give a brief introduction and to introduce our speaker for today.
Hello, all.
Jennifer?
Hi, thanks, Ned. I'm Jennifer Jaworski at the Illinois Department of Juvenile Justice, and I'm the chair of the Council of Juvenile Correctional Administrators Mental Health Work Group. Today's presentation was planned by the CJCA Mental Health Work Group. This group was formed over a year ago to help understand and improve mental health services in juvenile justice systems across the United States. CJCA realized that many of the mental health providers were struggling with the same issues: PREA, screening and assessment, trauma-informed care, substance abuse issues, evidence-based practices, and lawsuits over the lack of adequate mental health services, to name a few. By forming an administrative group of providers who oversee mental health services in juvenile justice facilities, we felt we could assist each other in addressing these issues. We thank CJCA and Ned Loughran for providing us the opportunity to meet monthly. We have spent much of the first year learning about the services each state provides in its facilities. We have come to realize not only our differences, but how much we share. Gaining knowledge of each other's state's juvenile justice operations has created a bond that allows many jurisdiction-to-jurisdiction conversations to occur. Members of our group support each other, and a wealth of information has been made available. The CJCA Mental Health Work Group also wanted to focus on a project to enhance its services at these sites. We determined that trauma-informed care is an important issue and one that we wanted more information on. Today's presentation is a result of those discussions. The CJCA Mental Health Group is working on providing a total of 4 webinars that will enhance our knowledge of trauma-informed care. We thank Madeleine Byrne for being first on the agenda. We hope that members of the CJCA Mental Health Work Group and their staff members are able to participate and benefit from these webinars. The next 3 webinars will also be quite exciting with some very knowledgeable presenters. They include Trauma Screens and Assessments by Patricia Keurig from the University of Utah, Trauma Treatment by Julian D. Ford from the University of Connecticut, and Implementing Trauma-Informed Care in Juvenile Facilities, Christopher Branson of the New York School of Medicine. We will update you on those dates. We will keep you informed of the dates and times of these very informative webinars. We thank you for your participation today and hope that you enjoy and learn from Madeleine's presentation. With that, I hand over the presentation to Madeleine Byrne. She is the Director of Treatment at the Texas Juvenile Justice Department. Madeleine?
Thank you, Jennifer. Good afternoon, everyone. This is one of my favorite topics to talk about. I think this is an incredibly important focus we need to take in juvenile justice. And so we have been offered a presentation through the National Center for Trauma Services Network that they have sent us training for our staff for juvenile justice, and our training department had this information available, and so I have basically adapted it to the PowerPoint that you guys are going to be looking at today. There will also be some opportunities for you to answer some questions to sort of capture some of the topics that I talk about. So with that, we'll get going. The first thing I want to do is talk about the definition of trauma. There are a couple of ways to look at trauma. We have sort of a generic definition that says that trauma is anything that occurs outside the normal human experience. Those are events that are abnormal to our normal daily, day-to-day life that most of us experience. But when you go to more of a DSM, Diagnostic and Statistical Manual for Psychology kind of definition, we have to look at anything that we experience that has real or perceived threat to life or bodily integrity. The life or bodily integrity of a loved one, or something that causes overwhelming sense of terror, horror, helplessness, and fear. And we're going to see as we go through this presentation how some of those, or if you've had that kind of experience, or if a person goes through these kinds of experiences, what the after effects will be and how that affects a person's behaviors, and how we see that in the juvenile population, and how we can tailor our interventions in order to help those youth manage those behaviors. We have to talk about it and really learn a lot about how trauma affects youth and children, is because it really derails normal child development. So what we see are many youth who end up in the juvenile justice system because as fallout, basically, of their trauma experiences. It changes our biology, especially brain development in children, and this results sometimes in emergency response system changes that are dramatic. And those emergency response system changes in the brain cause behavioral disturbances that we see often in the youth, and we can often misinterpret or misunderstand what the behavior is saying to us. So we have to, if we are trauma informed, we are better able to intervene and respond to the youth who have these behavioral abnormalities. Excuse me, the executive functions of our brain are the parts of our brain in the frontal lobe that manage our ability to self-regulate. So when we are afraid, they help us to calm back down. If we're angry, it helps us make better decisions about how to verbalize or express our anger. So these kinds of injuries to the brain send the wrong signal, and the behavior that person responds to is maybe something that's out of control in some way. What usually happens in the process and that moment of the experience of trauma is the body goes into fight or flight mode, and one of the changes that happens is cortisol levels start to rise. Cortisol is a stress hormone that helps us to cope with stress. So when we're going through something that's really extraordinary, let's say we're going through a car accident, our cortisol levels jump up to help our heartbeat faster and help our breathing speed up so that we can respond to that terrifying moment. And so, again, we have the physiological responses, as I just mentioned, to breathing and the heart rate and the blood pressure changes. But when a youth is growing up or a child is growing up and going through trauma, sometimes we see the cortisol levels and some of the other hormone changes restricting brain growth. Sometimes we see that trauma response or trauma effects in a child get in the way of caregiver-infant bonding. They can, over time, particularly if the trauma is chronic or sustained over any period of time, the child sees the world as hostile and sees maybe other people in the world as dangerous to that child. And so they begin to see other people in their world as having a hostile attribution. So they see people as dangerous and unfriendly, which is not how normal child development usually works. So what's happening in that child's brain is that they are encoding messages from other people and from their environment as dangerous, and that fight and flight response comes up too quickly, and they begin to develop habits that are more aggressive and more self-defensive. And of course, sometimes particularly in the juvenile justice world, we're going to interpret that more aggressive response as intentional aggression towards maybe the adults or towards other kids, and not understand that comes from improper encoding that happened early in childhood when they were getting traumatized. Sometimes children and adolescents who have been through trauma have difficulty interpreting facial expressions appropriately as well. So the National Child Trauma Services Network developed 8 essential elements that they recommend to be available and be sort of an effort that we all make as administrators and staff members in the juvenile justice system to consider essential elements that make up trauma-informed practices. So trauma behavior, as I began to discuss, you can see maybe unreasonable anger or expressed anger, hostility and coldness, difficulty with trust, perceiving danger everywhere where maybe it doesn't present so much danger to someone who's not been in trauma experience. They often will act guarded and anxious. So I wanted to talk a little bit about the difference between actual post-traumatic stress disorder and chronic trauma in the juvenile justice population. The youth that we're talking about with chronic trauma would be youth who perhaps grew up in a home where there was family violence or there's domestic violence that they witness, and so it happens over a period of time intermittently, and it lasts over a period of their development that becomes more entrenched in their responding and interpreting and encoding their environment. Excuse me. So 75% of delinquent youth have experienced trauma victimization. Now that's one person's version. I have seen numbers in the delinquent population of having trauma histories as low as 30%, but as high as 75 or 80. However, in Cook County, Illinois, it was reported that 93 of the youth had been exposed to at least one trauma, with the mean number of traumas equaling 14. If you think about that, that's pretty staggering. Those are separate trauma events. So that would include everything from I witnessed a shooting in my neighborhood, I was physically abused one time, I was beat up by other children, I was in a car accident, anything along those lines. There could be multiple traumas in one child that experienced many versions. Excuse me. The rates of PTSD in incarcerated youth is 8 times as high as other community youth. We are not always going to see post-traumatic stress disorder symptoms in the youth that we serve. However, over time, maybe before they've come to us, while they're in our care, after they're with us, they may have more active symptoms. So it's deceptive to say at the beginning of their, when the system is doing their assessment as they are brought into the juvenile justice system, we often won't see those trauma symptoms until much later. That can be because of several reasons. It may be just they don't report it initially, they don't feel comfortable saying those things, they minimize the symptoms. We'll talk more about that, but often as psychologists, we can look at a youth, and if we don't see PTSD, nightmares, flashbacks, and avoidance in spades, basically, we might say this youth doesn't have any difficulty with his trauma experiences. He's not having any reaction to that. But then later on in his care, he may have some of those symptoms kick up and evidence themselves, or he or she might begin to report those more easily as they begin to trust some of the adults in their life. Of course, we know, I think, that youth who've been through a lot of trauma, in addition to PTSD, they may have other psychiatric symptoms, as severe sometimes as appearing to have psychosis or hallucinations that are sometimes manifestations of trauma reactions and trauma symptoms. As you can see, there's a breakdown of one study that brought in evidence that youth have a higher propensity towards comorbid substance abuse disorders, depression, psychosis, ADHD, other anxiety, and suicidal ideation. So another study done on PTSD and chronic trauma from Massachusetts Department of Youth Services noted that some exposures might include injuries, childhood physical and sexual abuse, as I mentioned, witnessing severe injury or death, gang violence, and the breakdown that they saw was that 86% of those who endorsed symptoms experienced sexual abuse. 69% experienced physical abuse, and those who had both physical and sexual abuse, there were 84% of the population that had endorsed symptoms, and 100% of those youth also had noted physical, sexual, and being a victim of other violence at some time. So you can see from those numbers that a large portion of our clientele essentially are going to have been seriously affected by trauma. This study actually competed a little bit with the first one that I noted, that it says, again, 93% of juvenile offenders report at least one traumatic experience, but the average number being 6 as opposed to 14. That's still really high. And this study also compared them to service members returning from Iraq. So the essential elements that I mentioned, these are what we can do to respond well and to create a sense of safety in the youth that we are serving. So the National Child Trauma Network says we should maximize the child's sense of safety, both physically and psychologically, because we all know that growth cannot occur in the absence of safety. I think it's difficult to, in a lot of juvenile justice settings, to establish a real sense of safety for a child who's been traumatized, and for all of the children that we serve. The juvenile justice population tend to have all of these trauma triggers and traumatic symptoms that manifest as some aggressive behavior, defiant behavior that comes with just adolescence and comes with being a delinquent behavior. And so ensuring a child's sense of safety is difficult with this population, partly because they don't trust us to begin with, and because they are within a juvenile incarcerated population where there is less safety just through the expression of various behaviors. So what can we do to increase the youth's sense of safety is a question we should be asking every day. And asking ourselves, what do we do within the course of our work that might even trigger some of these trauma reminders? As we treat youth who've had traumatic histories, we teach them to notice when they have a trauma reminder, when something happens in their environment that brings up a memory of something traumatic that happened to them, and when they begin to have the physiological changes that go with that, and when they start to have their behavioral changes that go with having a trauma reminder pop up for them. So it's important that we understand sometimes the tone of our voice, sometimes a fight that erupts between two youth, sometimes just the rain and the storm outside might trigger a traumatic reminder for a youth. Youth who've been through tornadoes. This is Texas, where I'm from, and we see a lot of tornadoes, and I think there are a lot of youth who've experienced some version of a severe tornado in their history. We had also several youth who came over after Katrina, and they had a lot of hurricane trauma. I'm sure that in other locations you guys have other weather-related traumatic experiences that people have been through. These are things, if we stay awake to those and we understand how severe weather might trigger a trauma reminder for the youth, we might be able to help them manage those experiences when they're with us. Essential element number 2, we have to assist the children in reducing their overwhelming emotion. As I said before, one of the reasons we know something was traumatic is that that event elicited tremendous feelings: fear, anger, shame, helplessness, etc. And the child is overwhelmed by those feelings. When the traumatic reminder comes back, those emotions can emerge at the same intensity that they experienced them the first time. And that would be a flashback. That's where a youth is going to tell you, I think I just had a flashback. And they're extraordinarily upset at that point. That overwhelming emotion gets in the way of everything. It stops their ability to think clearly. They're overwhelmed with emotion, so they might be extraordinarily angry or afraid or feel so helpless they can't move. We see a lot of different kinds of expressions of that, but their ability to regulate what's going on with them is derailed completely. Sometimes during a flashback, they don't feel like they're where they are, so they don't recognize the environment that they are actually in. So traumatic, overwhelming emotions, sometimes the trauma is stored in their body in the form of physical tension and health complaints. So youth who have regular headaches maybe, or they have times when they feel sick to their stomach, they might be experiencing some of the reactions to their trauma, that trauma memories that might be coming up. Okay, element number 3. We can help children make new meaning out of their trauma history and their current experiences of their trauma history. So we talked about a sense of safety. And we're going to look a little bit later at what are some things we can do to help a child or a youth feel more safe within their world. Sometimes in our juvenile justice worlds, we get cemented into some practices that might be more rigid, more group-oriented, and less individualized to the youth who has some of this trauma history or has some of the mental health responses that are so difficult. We have to understand that they're disrupted encoding of their experiences. So their distorted, maybe, perception of what happened to them is something that they need some help in responding to and altering over time and getting some treatment for. They have difficulty communicating their feelings and being able to talk about what their experience is. They don't trust other people to want to hear what they are going through, or they don't trust that other people won't take advantage of something that they disclose about how they're experiencing nightmares, or if they're experiencing flashbacks, or if they're just wanting to avoid experiences and events in their treatment that might be upsetting and might be triggering for them. So to understand their trauma, the youth, we have to help the youth feel safe within their world. And we're going to have to understand what it is that makes them feel unsafe and help them manage that part of their environment while they're in the justice environment. So again, I'm going to ask the question, what can we do in our workspace that'll help youth make sense of and derive meaning out of their trauma history? Trauma-informed care element number 4, we are recommended to address the impact of trauma and its changes in the child's behavior, their development, and in their relationship. So we can help youth reinterpret or to understand differently some of the things that they have experienced. So when you have a youth who has begun to throw chairs as early as first grade, let's say, and he's in school and he can't concentrate, makes poor grades, that's really kind of unusual, and we help them understand that maybe some of their school performance might be related to some of the things that they used to live with, some of the experiences they've gone through. And it's one of the ways to help them begin to understand and make sense of and find meaning in the events that they had to suffer and how it showed up in their behavior later on, as opposed to, I'm a terrible student and I'm not very bright. Maybe they couldn't concentrate. Maybe they felt isolated and alone. Maybe they didn't trust teachers to teach them, and they didn't like it when teachers stood next to them to teach them different things because they didn't feel safe, and so their school performance suffered. These are the kinds of things we can help the youth to understand differently that makes more sense to their healing and helps them to begin to explore, well, maybe I can be successful in school. Maybe I can be successful in my relationships. Maybe I don't have to fight people off. Maybe I don't have to have peer relationships that are so conflicted. So there's other secondary problems behavioral problems that youth have experienced or expressed or repeated over and over again during their development that help to, again, derail the youth's recovery from trauma. So if they are acting out, if they're fighting, if they are so defiant with adults that they don't develop trusting relationships, it's very difficult for them to move to the next step of being able to heal and develop a relationship in which they can explore their pain and tolerate their pain and begin to resolve their pain. Some of these secondary adversities of failing out of school, being in the juvenile justice system, having their family so frustrated with them that they don't understand their behavior, it changes how this youth is able to cope and how they see themselves and how they see the world, and that traumatic lens through which they see the world stays distorted for a very long time. and it affects the family system. As I said, extended family begins to say, well, that's our troubled kid. That's our one that's in trouble with the law. That's the one that is so difficult and defiant, we just don't know what to do with them. So we have to help the family system as well. Trauma-informed care element number 5. We are recommended to coordinate our services. These youth need multiple system help in order to really address how extensively their trauma has affected their behavior, their families, their relationships, etc. And so the best practices in trauma-informed care are to have multiple systems on the same campus addressing elements of this youth's trauma and this youth's trauma expression to help them begin to alter the way they see themselves and the way that they have the rest of the world see them through their behavior. So when we meet with our multidisciplinary teams, or when we seek assistance from other departments on our campuses, or we refer youth to other services, it's important that we educate the other providers and other educators and other staff that are involved with that youth. If we educate them to what this youth has been through, so that we can help everyone see what kinds of interventions can be useful, and we can all develop plans around assisting this youth in stopping the destructive behaviors that are manifestations of his trauma, and begin to trust that the team is working to help the kid move forward and to resolve some of those traumatic symptoms. So it's important that we each take a leadership role in providing trauma-informed care and educating our partners and our other team members in developing a web of support. Trauma-informed care number 6. We are also recommended to use comprehensive assessment of the child's traumatic experiences and its impact on his development and the behavior that we see, and help all of that to guide the services that we present. If a youth isn't symptomatic of PTSD, then we probably don't treat that. But if he's having other behavioral reactions, then we probably do need to address that. His risky behaviors, we need to come up with interventions that impact that are trauma-informed and seen through a traumatic recovery kinds of lens, so that we're not punishing, we're helping the child to extinguish inappropriate behavior, but we're also helping him understand that this is fallout from traumatic experiences, and that we extinguish those behaviors and help him develop skills that he was not able to develop during his development because of the trauma. And then, of course, to make needed referrals, still in that sense of developing a team-like web to support the youth. Essential element number 7 is supporting the relationships around for that youth that the youth is engaged in, so that those are safe, positive, and stable relationships. We're going to talk in a couple of the case studies about how traumatic separation can have some of the same fallout, some of the same symptomatology that abuse has, or that experiencing some sort of traumatic loss might have. So we're going to talk about how even, say, a death in the family, particularly the death of a caregiver, a primary caregiver, can be very stressful to a child. Divorce is very stressful and can be traumatic, depending on how it all plays out. But part of the recovery process is having familiar, positive people in that child's life that are supportive and encouraging and help the youth work through the history of distrust and fear and helplessness that the child used to feel. It's important that we minimize the disruption in relationships. We fight with, here in Texas, we fight with case manager changes that are caused by a variety of sort of innocent changes, but at the same time cause disruptions for that youth in permanency. So if they're here for 9 months, they may experience the change of a case manager who's their primary contact person, their primary support person. And if they have that change, it feels to them, to the traumatized child, as if they're experiencing that permanent loss or that very serious loss that they experienced earlier. It feels the same to them and has effects on the child's ability to attach. And the last of the essential elements is number 8, to provide support and guidance to the child's family and caregivers. As juvenile justice professionals, sometimes it's a luxury to think that we're their primary person, and if we take care of them and treat them and provide services for them, that's all we have to do. But one of the things we forget sometimes is that this youth and his family will always be that child and that family. Their family goes on way beyond us, and it's so important that we find support, guidance, positive family members and caregivers that the youth can return to, because we are not the be-all and end-all of his development. And when the youth leaves us, he still has development that's going to occur. And if we have created a safe and nurturing environment while he's with us, we also should return him to an environment that is trauma-informed, that is resourceful and encouraging, and a family that will take them all the way through and understand behaviors in the context of the experiences they've had. And more than that, natural parents experience trauma when separated from their children. It's just one of those things that's built into much of the engagement we have with juveniles in our systems. Parents are traumatized by the separation, the children are traumatized by the separation, and these separations can be triggered over and over again by different functions of our system. So when there's a multidisciplinary team meeting and the parent comes to the meeting and the child is there and they talk about his progress and there's this therapeutic sort of moment, they're going to have to separate again. At the end of that meeting or at the end of their visitation period, they're going to have to separate from each other again. And some of that can be a re-experiencing moment for them. Sometimes that triggers other unresolved separations that they may have had earlier. We have a lot of work to do to help families to cope with their own histories of trauma and their shared histories of trauma and loss. So this is a really big topic that affects many people in our environments, our worlds, our scope of our work. These are the 5 questions that are going to be part of our polls that you can all respond to. So we're going to put up the first question: in what trauma-informed strategies are useful when we serve families? You have the opportunity to click on one of these and choose an answer based on some of the things we've already talked about. So in this particular question, you have the option to select all that apply. We're here to change youth behavior, not their parents. Trauma is cyclical and keeps repeating, so we cannot have any impact on the problem. Educating families as to the nature of trauma and its influence on behavior is useful. Helping youth and parents receive treatment for the trauma they have experienced, or both C and D. Oh, both C and D is not on there, I'm sorry. So select your favorite answers among those choices. And we'll go back to our slides. So, poll results. Most of you selected educating families as to the nature of trauma is important, and I absolutely agree with that. And most of you, even higher rate of you, selected helping youth and parents receive treatment for their trauma is critical, and both of those answers are correct. Those are great answers, good. All right, move on, because what we're going to do now is talk about two cases. These are cases that were presented through the National Child Trauma Network. And these are fascinating to me. And the way these are presented is to introduce you based on the reason for our incarceration on both youth and the perspectives of the different staff at the facility that takes care of this youth and the family members that are tied to them. At the end of each of the case studies, I'm also going to discuss with you, we're going to present some other questions and help you think through how would we intervene with this young person in a way that would be trauma-informed. So let's talk about Latifa for a minute. She's 15 years old, and she's from Sudan, and she's in the last month of a sentence for running from foster placements on several occasions and violating probation. When she's released, she'll enter her 5th foster placement and her first non-kinship home. And for those of you who don't deal with child protective care, non-kinship means somebody outside of the family. So her 5th foster placement since the death of her mother. Her teacher knows that she's a freshman, that she's good at reading and math, that she sits in the back of the classroom, but doesn't participate very much in class discussions. She doesn't have very many friends and doesn't want peers to know that she's a good student. So she's kind of ashamed of that and guards against the other kids knowing that she's a good student. She's often seen rocking in the back of the classroom and occasionally looks unaware that she's rocking in class when the teacher says, could you stop for a minute? You know, you're making noise or whatever. So the social worker or psychologist that's engaged with her knows that her father was shot and killed when she was 6 when they lived in Darfur. She has seen dead bodies because Darfur, I guess, was involved in some wartime violence during that period of time. She immigrated to Nebraska with her mother after her father died, excuse me. And the mom died then when she was 9 years old of cancer. So this youth has now lost both parents before she was 9 years old. And she is now living in the United States. She moved in with her aunt and uncle, but then her aunt died when she was 11. Months later, the uncle was injured and could no longer take care of her. So she's placed with her 24-year-old godmother. A year after that, the godmother died of a heart defect. This kid cannot pray for a break. Finally, she moves in with her grandmother. The grandmother wouldn't allow Latifa to do her schoolwork until all her chores were done. Latifa was required to do all the chores and all the cooking. Remember, she is now approximately 12. When the grandmother was angry with Latifa, she would throw her books away, her school books. Now remember, Latifa is a good student and likes school. The grandmother believes women don't need an education. The grandmother beat her with the skillet, so she ran away. She ran away approximately 10 times because she believed her grandmother hated her. The social worker said that homes are hard to find, so she needs to make it work with her grandmother. The medical staff at the facility know that she's overweight, that she has bruises from her beatings, from the grandmother, that is. A gynecological exam indicated that she'd had a recent pregnancy and pelvic infection, and she wasn't sure how the baby got there. So she's 12 going into juvenile justice, by the way. Grandmother said it couldn't have she was 15. She couldn't have been but a few weeks along, and the grandmother said she became pregnant while she was running the street. So security staff notes that when they see her, she doesn't sleep. She won't sleep. She doesn't talk to anyone. She hums quietly in her room but won't get in bed. Probably gets 2 hours of sleep. Follows the rules, and her room is clean. But during room searches, if staff aren't careful to put things back, she becomes very agitated and nervous, and she's been disciplined for refusing to do anything asked of her until the staff returned her room to the same way they found it. The staff see her as a model student, and she doesn't make eye contact, socialize, or have any friends within the facilities. She talks typically without any emotion and often only about superficial topics. Latifa reports that she dreams of her father's death. She thinks it's horrible going to the hospital to visit. She thought it was horrible when she had to go to the hospital to visit her dying mother. When her aunt got really sick, they put her in the same room. The aunt was in the same hospital room that her mother was. She's begun to think she's cursed. She dreams about her mother as well. She wonders if she's going to die too. She says, "The nurses say there's nothing wrong with me, but I think they just don't want me to know that I'm dying." Latifa liked living with her uncle, who was kind and gentle. He helped her with the homework and told her she could do and be anything. The move to the grandmother's house, she said, "I had no feelings at all, like something had been taken away from her soul. Only people I love die. I used to want to be a teacher, but I think that dream has to end because I'm crazy and I'm cursed. I don't have any more love to give to anybody or anyone. I can't see a future, and I doubt that I'll ever marry. I can't even be a mother because I couldn't protect the child that was given to me." You can see that she's shut off most of her emotions. She has a stunted perception of herself and a distorted perception of herself in her relationships. She's blaming herself. There's a lot going on there. The grandmother, Miriam says, or Miriam has experienced the loss of her own son to the murder in Darfur. Her daughter-in-law took her grandchild, according to her. Her perception is, my family was all here, my son was killed, and my daughter-in-law left and took my grandchild. My grandchild is now being raised in the United States with all these crazy new values that I don't buy into. And now I get this ungrateful, distant, disrespectful granddaughter that I have to take care of. So the traumatic events that we've just heard about, we need to talk about those. Certainly, knowing that your father is murdered would be traumatic to a child. It would probably be traumatic to an adult. This is a huge loss of a caregiver, but also it is a reminder to that child that the world is unsafe. Their perception, a child's perception of a loss of their father to a murder is, wow, nobody's safe now because my dad was taken away in such an awful way. She saw murdered people in the streets. And she had to move to a new country as a result of this. So everything that she knew was disrupted in her world. So dad's gone, my house is gone, whatever friends she had at the age of 6 in her school, all of that has changed, and that becomes very traumatic to the child because they have no control. So there's a sense that they're incredibly helpless. Then, of course, shortly thereafter, mom dies of cancer, and so that becomes another traumatic event. There's another huge loss, and the inability to grieve about it because there's no one supportive, whereas after the father's murder, at least she still had her mother to comfort her when she was afraid or to remind her that she could be cared for by her mom. Now both of her parents are gone, and there are very few emotional supports to help her grieve through those losses. The aunt's death comes less than a year later, or 2 years later. Within the next 2 years, she loses the aunt. So now it becomes all the people I love and care for end up dying. and the child walks away with a sense of, you shouldn't probably trust that anybody's going to stay with you because there's no evidence in her life that important people aren't going to go away very quickly. And then, of course, she gets that reinforced again a year later when the godmother dies. Suddenly, a young person who appeared to be healthy suddenly dies of a heart defect. In the meantime, she's removed from her uncle's care. So the one last remaining positive, supportive family member is taken away from her because he gets injured. Again, she's back to feeling probably tremendous helplessness because these things keep happening around her and affect her world drastically. She's physically abused by the grandmother, emotionally abused by the grandmother, in the sense of she's told that her needs don't matter, what she cares about doesn't matter. She's not supported. The grandmother is resentful of her being there, etc. We don't know if she was sexually abused while she's on the run or in the streets. According to Grandma, that's how she got pregnant. Maybe that's a sexual abuse event. We don't know. Pardon me. We can also delude ourselves into believing that youth that get arrested, children who get arrested and incarcerated is not traumatic, but it absolutely is. For one thing, they have another caregiver change in their world, and often an arrest for a child becomes a physical restraint situation or a time when they are surprised by the results of their behavior. So there's a long list in this young lady's life about what a long list of experiences very traumatic. So you can imagine that she's got a lot of responses to the various layers of the accumulated traumas. So we're going to talk about behavioral symptoms. We were reading about just a minute ago the ways that this youth has expressed traumatic responses, and her responses are her ways of coping with the pain and confusion and cognitive distortions she's left with from all of these events. So the teacher talked about she's emotionally withdrawn. She doesn't make friends easily. She doesn't talk in class. She's rocking and dissociating, sort of checked out emotionally. I think the security staff noted that she doesn't speak to people there, doesn't seek out friends or relationships with the staff. Certainly she has done, she's running away as a way to cope multiple times. She has emotional outbursts that to the staff seem to be sort of excessive, outrageous, maybe disconnected when she has her room messed up, or makes her world, her small area that she can control in terms of keeping her room super neat within the security area or within her dormitory. When they disrupt it to do a search, she can't handle it. So she has this dysregulation that provides really extraordinary reactions, overreactions. She's overweight, so we can assume that she has some overeating as a behavioral response. Doesn't sleep well, refuses to sleep in her bed, doesn't feel like that's a safe, either the safe space like her bed, or that that's a safe time, because falling asleep leaves you feeling helpless, of course. And then her hypercleanliness is another way to just try to have some control over your environment. Before we go on to Elijah, we can take question number 2. And the question number 2 is, what are some ways that intergenerational trauma impacts the youth and their families? When we're talking about Latifah, we saw that there is intergenerational trauma. Grandmother lost her son. Latifah is the child of the man who was murdered. All of these other losses, of course, affected the other parts of the family. But if you're answering this question, select one of these answers. Parents may have their own avoidance and denial and traumatic reactions. Parents have contributed to the youth's problem, so it doesn't matter what they feel. Or the youth have been the ones behaving badly, so their trauma issues are insignificant. I'm glad very few of you chose number 3, because we know that from intergenerational trauma, parents are going to have their own avoidance and their own denial. They're going to have their own symptoms that show up because they've been traumatized. Of course, adults can experience trauma just as well as children can. And parents have sometimes contributed to a youth's problems. So traumatic impact might be as a result of things that parents have done. Parents leaving, parents divorcing, parents abusing the youth. So sometimes they have contributed to the youth's problems. So let's talk about Elijah. This is a 16-year-old African-American male who was incarcerated for killing his mother's boyfriend. And we're going to kind of speed up a little bit because we're going to be a little short on time. He served probation for his first offense, which was a petty theft, a year ago. His teacher knows that he's currently in the 10th grade. He's performing poorly in class, except for history. His teachers often find him sleeping in class. Elijah says classes are dumb, teachers are boring, I'm tired all the time. He says there's no reason for him to pay attention since he's going to be in here forever. None of his teachers care about him, he says, because I'm just another paycheck to them. Elijah's mom, Edith, has not come to visit him since he was admitted to the facility, and she schedules but cancels at the last minute. The only thing he likes these days is art therapy. His mother says she was not really there for Elijah because she was released from the hospital after she wasn't really there for him right after she was released from the hospital after the boyfriend beat her up. She was hurt so badly that her mother had to take care of Elijah for about 2 months. She says, Mom says, he was a good boy, he was sweet and loving. She decided not to date anyone for a while and described that period of time after she was beaten up as great because it was just me and him. Within a year of that hospital stay, she was married again, and she was pregnant. So Elijah had a brother named Kyle, born a little bit later. Elijah was affected by a car accident that killed his brother. The brother was, I think, 3 years old when the family was in a car accident and the baby died. So Elijah began to refuse to ride in the car. He had nightmares and would do anything to stay awake, and often he would be found singing to himself in his room. Elijah's history is the stepfather was drinking more and more. And they would argue. The more the mom and Robert, the stepdad, fought, the more protective Elijah got. He'd stand up to Robert. Most of the time that he'd stand up to him, Robert would calm down, but eventually that wasn't enough either. Elijah started screaming at Robert and throwing things and finally hitting him. Robert turned his anger from his mom, Elijah's mom, to Elijah, and he began to beat Elijah frequently. Elijah began to look as if he was in outer space. He was always drawing. It was the one thing that made him happy. Mom started dating Robert again after they separated, and 9 months into the marriage, he began to beat Elijah and stopped hitting Mom. Elijah began to avoid coming home, and at 14, Robert beat the mom again over a picture that Elijah broke. And when that picture broke and he heard his mom screaming after Robert started to beat her, Elijah was triggered and ran upstairs and took a baseball bat to Robert and killed him, and the police arrested him. Now that he's in custody, the security staff sees him as wearing a prominent scowl. He's placed on the mental health unit. Staff members have been able to talk to him about his early abuse, but he has trouble handling things that challenge him. He starts fight with youth unprovoked. He describes feeling like his body fills up with hot and wants to punch people, and then there's no one to help him, like he has been left there all alone. He refuses to go to sleep at night as well. He's been singing loudly during the evening routine and getting even louder when he's sent to his room. Medical staff say that he appears physically healthy with minor scrapes, signs of multiple rib fractures and old fractures to both his left and right humeri, complaining of extreme exhaustion, suffering from fatigue, and they determined it was depression. Social worker and psychologists know that he's the older of two sons. He lost his 3-year-old brother in a car accident when he was 12. Ben, the first boyfriend, came home drunk a lot and became violent. Ben began throwing things and hitting him, beat Elijah on multiple occasions, left for work, and didn't come back, ever. Neither Elijah nor his mom ever saw him again. In counseling, he remembered being 3 years old, seeing his mother nearly beaten to death by a boyfriend, and he dreams about that attack. The evening of the crime, Elijah was 14. Robert was really angry when he came home from work, and he heard the sounds of Robert slapping his mom, throwing her against the wall. When he heard his mother screaming without thinking, Elijah grabbed a baseball bat. He beat Robert about the head until he fell down and stopped moving. He says his nightmares are so horrible he's afraid to fall asleep at night. Using Elijah's art time as an incentive for his consequence reward program. So the traumatic events in this youth's life: death of his brother is the first one, and witnessing the violence against mom happened when he was 3, 12, and 14. His mother was absent for 2 months when she was in the hospital. Ben left suddenly, even though he was a negative relationship in his life because of the violence. He was a caregiver for a while, and he left suddenly and never returned. That's traumatic to a child. He had a period of time with his mother where it was just me and him, as she stated, but then suddenly she starts dating Robert. Physical abuse that he experienced by both stepfathers. The acts involved in his offense could be traumatic. The ability to kill somebody with a baseball bat does traumatize a child. It's overwhelming, it's horrifying, it develops a tremendous amount of fear in the person. And so we can't ever overlook the effect of an offense on the youth, and perhaps they have some traumatic responses to it. Of course, he was removed from his home when he was arrested, and he was incarcerated and now has new caregivers to develop relationships with. Let's go back to the next question, question number 3. What happens when birth or foster parents, adoptive or professional caregivers don't understand or know how to respond to the way trauma has impacted the child? And your choices are: nothing happens, the child will get over it on his own. Birth parents sue the state. Youth overreact to unpredictable triggers and often don't receive the care they need. State-run facilities get shut down. So you would select one of these choices in your quick poll. Yeah, so what happens when caregivers don't understand how to respond to the way trauma is impacting the child? Youth do overreact with unpredictable triggers. The child doesn't get over it on his own, by the way, as all of you have determined. Sometimes state-run facilities can get shut down. I think one person or a couple of people chose that as an option. I suppose that's one of the possible after effects. But the primary answer here is sometimes youth don't get the care they need, and they certainly can overreact to what's happening around them. So let's go back and look at what the traumatic behaviors were for Elijah. We know that he was provoking his peers and fighting. So aggression began to be an expression for him when he began to have a lot of fights with his peers. However, it was also one of the things that led to his final offense, beating up Robert in the end and actually killing him. So the singing would be one of his behaviors that he used to cope. It didn't violate anybody else's rights other than maybe keeping his peers awake on the dormitory, but his nightmares were certainly significant. Not being willing to come home, not being willing to ride in the car. Those are avoidance behaviors that are evidence of PTSD. So when we avoid certain trauma triggers, that's one of the ways that I think psychologists and other mental health professionals might note that this youth might have some trauma history. Certainly committing a murder is an extraordinary traumatic behavior. His depression, hopeless attitude, and poor attention span that we learned about in his school are very likely to be traumatic responses. His difficulty sleeping in response to his nightmares, his difficulty self-regulating and calming down probably at night had a lot to do with that. His permanent scowl, these are emotional responses. His poor distress tolerance, not being able to put up with minor things that might happen in his environment that scare him, make him angry, etc. And his difficulty with trusting adults. He had some dangerous adults in his life. He also had his mother leave him for a period of time in his childhood. And so he had difficulty attaching again. And of course, his poor school performance that was related to these other issues up here, his poor attention span, his hopelessness, and his depression. All right, so we can take our poll question number 4. I believe I've gotten these out of order a little bit. What are key trauma-informed strategies that I can use in my role as a juvenile justice professional? Develop relationships with youth that are trusting relationships. Another option is to keep the consequences for misbehavior as harsh as policy allows. Another option is make sure every youth sees a psychologist because they all have PTSD. Another possibility, extend the youth's time in secure care until they get over their trauma. Or possibly link youth and their families to appropriate services to meet their needs. All right, so primarily folks have selected the following answers. Develop relationships with youth that are trusting, absolutely. That's probably the responsibility of everybody who works in the juvenile justice system. So everybody from the cafeteria workers to the superintendents of the campuses or the psychology staff or the juvenile justice officers, case managers, we are really tasked with developing relationships that are trusting and helpful, supportive. I would disagree that we need to make sure every youth sees a psychologist for PTSD. I think often it's helpful for every youth to see a psychologist for assessment, perhaps. Certainly at the beginning of their care, it's a good idea to do some psychological assessment just to determine whether or not that is needed, at least some screening. Extending the youth's time in secure care is probably not a great idea. Usually, mental health treatment is most effectively done in the community if the youth can be safe in the community. So that extending a youth's time in secure care should really only happen because the youth's behavior isn't safe for the community. Linking youth and their families to appropriate services is critical. Once we have determined that a youth can live successfully and safely in the community, we should begin to develop, we should have already begun to develop extensive service provision in their home communities that link them to what they need to resolve their traumatic symptoms and to begin to reintegrate back into their community. All right, let's do quick poll number 5. Looking at what happens when these traumatic issues are not addressed. What we see when youth are not have their trauma addressed, or when trauma-informed care is not provided, youth behavior can be misinterpreted as angry when the youth is really scared or overwhelmed. Juvenile justice staff intervene with harsher consequences than are appropriate for the behavior to be expressed. Youth may not be ready to return to the community. Possibly youth don't receive the care that's appropriate to their need, or all of the above. And a lot of you have been paying attention because you selected all of the above. All 4 of these things are possible when trauma-informed care is not provided. Sometimes staff will misinterpret a child's outburst as primarily angry and aggressive, when what the child is expressing is he's overwhelmed and he doesn't know what else to do with all of his emotions. And if we intervene at a level that helps him self-regulate, rather than taking it on as staff are now in danger, we might be more effective in responding to this youth's needs. We need to help kids, when we intervene with youth who are having traumatic reactions, we need to be as supportive as possible and give them also the opportunity to restore their relationships. So when they do have an outburst, it's appropriate to have some consequence because that's inappropriate behavior, but at the same time we have to give them short enough consequences that they can recover quickly and begin to restore those relationships that they had begun to establish, those trusting relationships that if they've yelled at staff or they have cussed the staff out, they need the opportunity for apology and forgiveness and the opportunity to begin again and try again and change their behavior the next time. Sometimes youth are not ready to return to the community because their reactions tend to be too violent, or they're too out of control, or they're unable to self-regulate appropriately enough to keep their family safe if they were to return to their family. So those kinds of things have to be assessed on all along through the youth's stay with us. Sometimes the kids don't receive the care that's appropriate for their mental health, for their behavioral disturbances, if we don't address the trauma sources. And that when the youth doesn't get the kinds of services that help him begin to self-regulate and sort of restore some of his cognitive distortions and get his thinking back to where it could have been without the trauma. So good deal. That is the end of our presentation portion, and now we are at a point where we can ask questions and answer questions. So we will shift to that portion of the presentation.
Great. Thank you so much, Madeleine, and thank you, all of you, for completing the poll, the 5 polls, and sending in some really, really good questions. So, Madeleine, here's the first question from one of the participants, that they're seeing the youth coming from some of the urban communities are perhaps more than a little desensitized to certain traumatic events because they're common and many of them are intergenerational. So the concept of needing to address the trauma is denied. How do you get a youth or a family to see a need to deal out triggers to trauma reminders and a need for regulating their intrinsic need for safety versus a reactive, overwhelming emotion? that was a lot, so I'm going to repeat the end of it. So the concept of needing to address the trauma is denied. Therefore, how do you get a youth or a family to see a need to deal out the triggers to trauma reminders and a need for regulating their intrinsic need for safety versus a reactive overwhelming emotion?
Okay, that's a great question, very involved. So often folks that have experienced particularly chronic trauma are going to have a lot of numbing and a lot of denial and a lot of suppression of those symptoms, and so they've practiced ways to push it away. And so in our environments, when the youth is in custody and they're surrounded by staff and treatment opportunities and educational opportunities, we have and sometimes during parent visits or family sessions where we can do some family therapy, we can help do a lot of education about what trauma is about and about the primary symptom of PTSD really is avoidance, and that avoidance encompasses so much. So a youth who says, I have no problems with trauma, I don't have any symptoms of trauma, is truly telling the truth, except for the fact that they may avoid things like going to group. They might, and the family might avoid coming to visit the youth. The family might avoid acknowledging things that did occur in their history. An example might be, I did a family session with a family where the youth was telling the family, let me tell you about some sexual abuse that I experienced within our family, and I want us to talk about it. And the mother and sisters were like, that didn't happen. I don't know what you're talking about. We don't want to go. You aren't allowed to say all that. Why are you telling these staff these things? That's the family's way of coping with their own traumatic history. And then down the road, as you begin to work with that family and educate them to, this is how it's showing up in your son's behavior, and the son describes his emotions, over time they begin to look at, yes, that did occur, and they can begin to work through all of those experiences. You help them, mostly you get there through education.
Thank you, Madeleine. So the next question is, pondering the information that you've been sharing, especially the case histories, what do you feel are some of the significant factors that would lead a youth from very early on to go in either direction, either during adolescence or adulthood, meaning living a well-developed, goal-oriented life, or going down the wrong road, the criminal road?
So factors that might divide those who cope well and those who don't, or those who cope in a more delinquent process. Some of it the influence of the family. So if the family tends to respond to difficult situations by violating other people's rights, often I think I'm probably talking to an audience of folks who experience families who our youth tend to have families that have been incarcerated, that have violated the law, that have had criminal histories. So one of the things they've experienced growing up is watching the adults in their world behave in this way. So they think that might be something that helps me cope. And so their coping strategies would start with maybe criminal behavior or violating somebody else's rights in the process of trying to feel better and try to regulate their discomfort. So that might be one factor. I think the lack of emotional resources might, within the family or within the neighborhood, might set a child up to act out in the community more, to perhaps have their coping behavior show up more at school, that sort of thing. So kind of where they're coming from, what the dynamics of the family are, and what's sort of their influences have been all along the way, and the resources of support or lack of support would probably be the factors that had the most influence, I would think.
Okay. And this is one that's a common problem in many jurisdictions because so many facilities are built away from the urban population. Right. So, Madeleine, what would you say are some of the practical ways to support the family or the caregivers when there's a single statewide facility and the family and caregivers might be located several hours away? Some are actually up to 4 and 5 hours away.
Yes. We experience that in Texas, of course, because Texas is geographically so immense and we only have 5 institutions. So what we have developed over time, we have in each community where the facilities are, we have community resource councils, and they are basically volunteers and folks who generate funds that help with bringing families to the facilities. So we send them bus tickets and gas cards and pay for hotel stays, etc. So we bring the families to us by getting some of those funds paid for by volunteers. I think we do also quarterly family days where the families are invited to come to the campus for a full day kind of full of activities where it's worth it to them to come, and they can meet with all the staff, they can have family therapy sessions, they can have visitation that is more extended. They can do more activities actually interacting with their youth rather than just sitting across the table from each other for 2 hours. So family therapy, family recreation days are really powerful. We do furloughs now that we didn't do before, where the youth can go home for short stays for 1 day, and the staff will go with the youth to the house as they're beginning to start the reentry process. We'll do a day furlough, then we'll do a weekend furlough, then we'll do 3 or 4 days, and then we do the release or the transition to the halfway house. So there are ways to engage families. We also will do webcams. Every case manager in our system has a webcam so that we can do visual meetings with the kids and their families. So there are a variety of ways.
Great. This is a question from one of the teachers who is participating today. So what can we as teachers at secure facilities do when we determine that a student has significant issues that are not treatable at the facility where the youth is housed?
That's a great question. So that's time to refer. That's time when you want to connect with your web of resources on your campus. And so you might refer them to the psychology department to do more assessment. You might refer them to, if you have social workers or mental health professionals on the campus, have that person assess that youth and take a look at what you're seeing and make referrals. You probably have some people who are responsible for placement and for assessing the need for, various levels of care. And those kinds of positions, you want to access those resources among your teams.
Good, and that leads to the question about sharing information across departments or agencies on individual youth. How does Texas share, say the information on Latifah and Elijah? That was a rich body of information you gave, so important to those who are treating the youth. So therefore, how do you share that across your own departments in your agency or with mental health and child welfare or education when it's their turn to help these youths?
Also an awesome question, because there are a lot of barriers to that. We have our facilities are fairly large, so some of them house 250 youth, and so we have a medical department, and our medical providers are contracted, and they serve the adult system and the juvenile system in our state, and they have very strict HIPAA barriers, basically, in terms of communication, but they're appropriate. They're appropriate because of the HIPAA rules. And so there is a certain amount of information that only the psychology staff can access. And then when the educators and the case managers and the dorm supervisors and the psychology staff all get together once a month to do their multidisciplinary meetings, that psychologists can provide a certain amount of that information to the team. Certainly, all of the information that is being generated by all the different departments during the youth stay is basically accessible across the team in those MDT meetings. So yeah, there's some barriers and there's some access that is appropriate across the team and in certain meetings where you can share certain details that are related to the need for the youth's treatment. I don't know if I answered that clearly.
Okay, thank you. I think you mentioned motivational interviewing in the beginning, but are there some other assessment tools that you use at the Texas Department of Juvenile Justice that you think are useful to uncover trauma?
Yes. We start with the MAISY, and I think a lot of people use that at various levels of juvenile justice intervention. So sometimes in juvenile detention, sometimes when we are doing those initial assessments. In our system, when the youth they're committed to the state facility, the secure care, we do a MAISY and we do a psychological assessment. In that MAISY, there's questions that load to the question of trauma history. Often, as we've talked about, in that initial moment, the youth is going to deny, oh, nope, never experienced any of that. However, if there are some things that are triggered or noted or endorsed at that point, we'll do further assessment with something like a trauma symptom checklist, where the youth, it basically asks, have you ever witnessed any violence? Have you ever been physically abused? Have you been sexually abused, et cetera, et cetera, et cetera? And it has several items on it, which assesses for better information. In addition, then once the youth has arrived at the campus, all of our psychology staff are trained in trauma-focused CBT. So we are able to explore that even further once the youth gets to their permanent location. So we look at that quite extensively here.
Okay, and the final question is, how are the schools involved? And this could be other agencies as well, a mental health agency in the community, but how are schools and other agencies involved when students go back to their regular schools or go back to the community and need follow-up counseling?
When the youth leave our secure care or our halfway houses, we set up services for them in the community. So if we know that that youth still needs mental health services, we're going to set that up before they even leave secure care. All of our halfway houses are part of our system, so they also will provide some of the mental health services. Once they get out onto parole and into the community, we will have set up those services through our statewide system, and very specifically may even have hooked them up with some therapist who knows, who gets all the records, et cetera, and who continues the treatment. So that continuum of care is super important when the youth is leaving our care and the treatment environment that we have set up for him.
Great. That's a very good answer. And those are all the questions we had. And just before we conclude this webinar, I want to urge all of you that as you sign off, there'll be a poll. It's a very brief poll just to give us some feedback on today's webinar, and that helps us planning future webinars. And remember, as Brendan mentioned earlier, today's presentation and the video recording will be available in follow-up emails, which will go out within the next 24 to 48 hours after the webinar. And please look for information on future webinars. If you're on our mailing list, and you are because you signed up for today's webinar, we will send out information on the next webinars, and we're also going to have 3 webinars throughout the year on reducing the use of isolation in facilities. We had one last year. We're going to have 3 more this year. So follow our blog at CJCA.net and follow us on your favorite social networks. And Madeleine, I just want to thank you so much for all the preparation and time and the engaging webinar that you produced this afternoon. And Jennifer, thank you so much. And you and the Mental Health Committee, CJCA Mental Health Work Group, for organizing and planning today's webinar. And Brendan Donahue from the Performance-Based Standards Learning Institute, thank you for producing our webinar today here at the CJCA office. So thank you very much, everybody, and we hope to see you at the next webinar.
Thank you, Ned.
Okay, bye-bye now.
Bye-bye.